In this lecture, we're going to do a quick review of the assessment of the gastrointestinal system, how it relates to the liver. So we just saw this slide in our last exam grouping, so we won't go over that, nor will we discuss some of these other things. The history is going to be a little bit different when we're talking about liver, only because we're going to have to add in so many psychosocial history pieces of information, and we'll discuss that later as well. We're going to have to talk about drug use, alcohol use, all very sensitive topics to patients. Sexual history, these are all things that we have to be very sensitive about. Just a really quick refresher, the pancreas is a fish-shaped organ that sits behind the stomach. It spans from the duodenum to the spleen, and it includes two major cellular bodies. The pancreas is made up of exocrine and endocrine cells. So the exocrine aspect of the pancreas consists of cells that secrete enzymes, and those enzymes are needed for digestion of carbohydrates, fats, proteins. These enzymes are trypsin, chymotrypsin, amylase, and lipase. And as you will hear later, amylase and lipase are some labs that we will review if the pancreas is suspected of being diseased. The endocrine cells that are associated with the pancreas are, don't forget, endocrine is hormone, so these endocrine cells are made up of the islets of Langerhans with alpha cells that produce glucagon and beta cells that produce insulin. The liver is the largest organ in the body other than the skin, and it's mostly located in the right upper quadrant of our abdomen. It includes hepatic ducts. There is a right and a left hepatic duct, and they transport bile from the liver into the common bile duct and then into the duodenum. Or the gallbladder, depending on if it's going to be stored or used. The blood supply, the liver receives its blood from the hepatic artery and the portal vein, and about 1.5 liters of blood flow through the liver every minute. So when we talk about the liver being very vascular, it is very vascular. So any procedure that's being done on the liver is going to take some serious consideration about blood flow and making sure that we're being cautious of bleeding concerns with patients. Functions of the liver are storage, protection, and metabolism. As far as storage goes, the liver stores a lot of vitamins and minerals like iron and magnesium, and the fat-soluble vitamins like vitamins A, D, E, and K. Protection, the protective function of the liver involves phagocytic Kupffer cells, that's Kupffer, and they engulf harmful bacteria by phagocytosis, and anemic red blood cells. The liver also detoxifies harmful compounds like alcohol, drugs, and any other chemicals that the body comes in contact with that need to be detoxified. This is why, as we age, we are significantly more concerned about drug toxicity, because as liver function decreases, and we're dosing a patient the same way, we might have a buildup of even intended drugs in the system, because the liver cannot detoxify as its function decreases. Metabolism, the liver metabolizes proteins. They break down, so the liver breaks down amino acids to remove ammonia and then convert it to urea, which is excreted by the kidneys. It breaks down plasma proteins and synthesizes plasma proteins, including albumin, prothrombin, and fibrinogen. The liver also metabolizes carbohydrates, and that involves the storing and releasing of glycogen. Because as the body's energy requirements change, we may or may not need glucose, and so the body stores the glucose in the liver as fat. The liver also synthesizes, breaks down, and temporarily stores fatty acids and triglycerides. And it also continuously secretes bile, and that bile is necessary for the breakdown of fats. The gallbladder is located beneath the liver, and it's drained by the cystic duct, which joins the hepatic duct to form the common bile duct. The function of the gallbladder is it collects, concentrates, and stores bile from the liver, and then it releases bile into the duodenum when fats are present. Let's talk about some diagnostic tests in regards to the hepatobiliary system. As far as lab goes, some of the labs that are important for the liver are prothrombin time, AST and ALT, bilirubin, serum ammonia, urobilinogen. So as far as the prothrombin time, the liver is the source of proteins involved in coagulation. So prothrombin time, which measures the rate at which prothrombin is converted to thrombin, and all of that is dependent on vitamin K clotting factors, this is the mechanism of action by which warfarin works. So we measure the prothrombin time, or PT, because if the liver is damaged, the prothrombin time will be prolonged, because the prothrombin takes longer to be converted to thrombin, therefore increasing bleeding times. AST and ALT. AST is short for aspartate aminotransferase, and ALT is short for alanine aminotransferase. These are two enzymes found in the liver. They're also found in other organs, so we can't call them specific to the liver, but they are good indicators of liver damage. They're elevated in most liver disorders, but they are highest in conditions that cause liver necrosis, like severe viral hepatitis and cirrhosis. Amylase and lipase in the serum, those may indicate acute pancreatitis, but not extensive pancreatic necrosis, because at that point there are too few pancreatic cells to manufacture enzymes. So it's almost like they peak before the pancreas gets too damaged, and then when it becomes too damaged, it can't even show that it's making any enzymes at all. Amylase and lipase in the urine. In acute pancreatitis, renal clearance of amylase is increased. So we'll see an increase in amylase in the urine. Bilirubin is the primary pigment in bile, and this is an important test when we're measuring jaundice and evaluating liver and biliary function. Serum ammonia can be used to measure hepatic function as well, because when the liver is damaged, we can recognize that there's severe hepatocellular injury. So elevated levels of serum ammonia are seen in conditions that cause severe hepatocellular injury, and that would be cirrhosis or fulminant hepatitis. Urobilinogen is a form of bilirubin that's converted by the intestinal flora and excreted in urine. This test would be useful when we're evaluating hepatic and biliary obstruction, and we often see an elevation in urobilinogen, so bilinogen in the urine, before jaundice is noted. Some diagnostic tests that we utilize for the liver are percutaneous transhepatic cholangiography, or PTC, and that is an x-ray of the biliary duct system. So what they do is they insert dye through the liver into the intrahepatic ducts, and they might do this when a patient has jaundice or persistent upper abdominal pain, but we don't usually use it as a diagnostic test. It's usually more of a method to treat things that we have seen on other diagnostic exams like an ultrasound or an ERCP. CT is a non-invasive cross-sectional x-ray, and with a CT we can detect tissue densities and abnormalities in the abdomen, including the liver, pancreas, spleen, and biliary tract. MRIs also might be indicated if a provider wants to get a closer look as well. Endoscopic retrograde cholangiopancreatography, so ERCP, is a visual and radiographic exam of the liver, gallbladder, and bile ducts and pancreas. And this is going to be used to identify cause or location of obstruction. They can also use an ERCP as therapy, and this would be if they're going to remove gallstones or place stents in the bile ducts to keep the bile ducts open. They can take biopsies during an ERCP. In your 8th edition of IGGI on page 1094, there are some nursing considerations that you should look at for an ERCP.